Alaikum wa rahmatullahi wa barakatuhu. Bismillahirrahmanirrahim. Dear students of fourth year MBBS, today we will discuss congenital and few of the secondary glaucomas. The learning objectives of this lecture are that at the end of the lecture you must know what is congenital glaucoma, what are its types, clinical features, how can you diagnose and treat the congenital glaucoma. What are secondary glaucomas? Particularly, you must know lens-induced glaucomas, their pathogenesis and treatment. So congenital glaucoma is also called ophthalmos. At the eye looks like bulge-like bluish eye having larger size. So what is the classification of congenital glaucoma? It may be true congenital glaucoma. The rise of intraocular pressure is at the intrauterine level and it is about 40% of the cases. Primary infantile glaucoma is the most common, 55%, and the intraocular pressure elevation is before 3 years of age. And juvenile glaucoma is the least common, intraocular pressure elevated after the 3 years up to 16 years of age. And few causes of secondary congenital glaucoma, where other diseases are involved to cause the congenital glaucoma, along with ocular developmental anomalies. So there is anterior dysgenesis, trabacular dysgenesis, and iridia. Certain ocular diseases may cause congenital glaucoma at the persistent hyperplastic primary vitreous, retinopathy of prematurity, retinoblastoma, and systemic disorders like Sturge-Weber syndrome. In Sturge-Weber syndrome, the features of the Sturge-Weber syndrome are that there are leptomeningeal hemangioma, port wine stain on the face, and ipsilateral glaucoma on where the port wine stain is present along with episcleral hemangioma. So primary infantile glaucoma, it is mostly sporadic, and 10% of the cases are having heredity of autosomal recessive with incomplete penetrance is there. Considering the pathogenesis, it causes the impaired outflow of aqueous due to maldevelopment of angle of interior chamber, that is called trabecular dysgenesis. So it is not associated with other major ocular anomalies. As far as incidence is concerned, it is 1 into 10,000 live births. It is most common in males. 60% of the males are affected. And bilaterality is about 75%. So as far as intraocular pressure is concerned, 40% have the raised intraocular pressure at birth, 80% in first 6 months, and 90% in the first 1 year of life. So what are the clinical features of primary congenital glaucoma? First of all, the symptoms. The parents noticed corneal haze, corneal clouding, lacrimation means watering of the eye, photophobia. The neonate cannot open the eyes in the light, blepharospasm and reduced visual acuity. And of course, the patient noticed bulge-like bluish eyes, bigger eyes. Here you can appreciate the corneal haze and the blepharospasm and photophobia in case of congenital glaucoma. And what are the signs? How can you diagnose a case of ophthalmos? Reduced visual acuity is there, intraocular pressure is raised, corneal diameter has the bigger diameters, enlarged corneal diameter, corneal edema may be there and breaks in descent membrane, which causes influx of aqueous into the cornea, causing so many complications. Later on, corneal scarring. So deep interior chamber, it may cause the axial myopia, and the gonioscopy shows anomaly in the angle structures. And if you see the fundus, optic disc show the cuppings. Here you can appreciate the HABSTI. HABSTI are the heel breaks in the descent membranes, curvy linear horizontal lines. And this is the end stage of the ophthalmos having vascularized corneal opacity. Usually the individual is unable to see. So before diagnosing the case of congenital glaucoma, you must consider the certain other diseases to rule out the parameters as we have mentioned. Raised intraocular pressure may be due to retinoblastoma, retinopathy of prematurity, persistent hyperplastic primary vitreous, and excessive tearing present in congenital nasolacrimal duct block. But in this case, visual acuity is normal, cornea is shining, normal, and no other abnormality is noted. And certain diseases in which corneal enlargement is there, as megalocornea, and in high myopia, cornea looks to be bigger. Corneal clouding in certain diseases may be due to birth trauma, hereditary corneal diseases causing the corneal clouding, and the corneal malformations. You must rule out these diseases. How will you manage the case of congenital glaucoma? You must do examination under anesthesia. There you measure the corneal diameter. The normal diameter of a neonate is under the 12 millimeter. If it is more than 12 millimeter, it is suspicious, and above or 14 millimeter is diagnostic. Then you do the gonioscopy and see the angle of the anterior chamber, and then measure the intraocular pressure with the Perkins handheld tonometer. Here you can appreciate that the intraocular pressure is being measured by the Perkins handheld tonometer, that is a type of applanation tonometer. What is the treatment of congenital glaucoma? The role of medicine is very, very limited. They cannot be used as a long term. But until we do not intervene surgically, we can use the medical treatment using prostaglandin analogs, beta blocker, and topical dorzolamide in combinations. But surgery is the answer. Different types: goniotomy, trabeculotomy, trabeculectomy, and ultimately the artificial drainage shunts. In goniotomy, we enter into the anterior chamber and give a cut into the trabecular meshwork. Here we need the clear cornea, but it is usually not successful. If it is, then we do the trabeculotomy. In trabeculotomy, we raise a partial thickness scleral flap, enter the goniotome into the canal of Schlemm, and then rotate it into the anterior chamber. So when the cornea is cloudy and angle of the anterior chamber is not visible, we do the trabeculotomy, sorry. And usually the goniotomy and trabeculotomy are not successful. We have to do the trabeculectomy, and particularly with the antimetabolites, mitomycin, C, or 5-fluorouracil. Here we raise a partial thickness scleral flap, then we cut a peripheral iris along with trabeculum so that a new channel is created bypassing the pupil. The aqueous passes directly into the anterior chamber from this hole, then this cut trabeculum underneath the scleral and subconjunctival space. And it is usually successful when it is done with along with the antimetabolites, mitomycin C or 5-fluorouracil. But if all the surgical measures fail, then answer is artificial drainage shunts. Molteno implants and Ahmad glaucoma valves are available. And here you can appreciate the Molteno valve in place. It is shown as a diagrammatic way. So this is all about congenital glaucoma. Now we briefly discuss few of the secondary glaucomas. What are the secondary glaucomas? These are the glaucomas which develop secondarily to any other ocular disease. They are of two types, open angle and angle closure type. Here you can appreciate the ciliary body aqueous is secreted by the ciliary body into the posterior chamber. Then it passes through the pupil into the anterior chamber, passing through the trabecular meshwork into the canal of Schlemm and ultimately into the episcleral vessels. So if this angle is open, and this open type of secondary glaucomas are three types. Pre-trabecular, where angle is open but the aqueous cannot approach to the trabeculum, and trabecular causes and the post-trabecular causes. So this is the open angle type of secondary glaucomas shown, and these are in this picture you can see the closed angle type. So open angle secondary glaucomas can be divided into pre-trabecular, then trabecular and post-trabecular. In pre-trabecular, aqueous outflow obstructed by membrane covering the trabeculum. Fibrovascular tissue, neovascular glaucomas, it covers the trabeculum so the aqueous cannot reach to the trabeculum. So endothelial cellular membranes proliferation, epithelial cellular membranes proliferations. And trabecular causes are clogging up of meshwork. Problem is there in the it causes secondary diseases cause the problem at the level of trabeculum. So pigment particles, red blood cells, degenerated red cells, macrophages and lens proteins, they can clog the trabeculum. Or proteins, hypertensive uveitis due to lens protein causing the rise in the intraocular pressure, or the pseudo exfoliation material deposited into the trabeculum. And the post-trabeculum causes are where the aqueous outflow is impaired due to elevated episcleral venous pressure. It may be due to keratoconus fistula, Sturge-Weber syndrome, or obstruction of the superior vena cava. So what are the secondary angle closure glaucomas? In these cases, aqueous outflow obstruction is due to apposition between peripheral iris and the trabeculum. There are two types, with pupillary block and without pupillary block. With pupillary block, seclusio pupillae, where posterior synechia are there, occlusio pupillae, where whole of the pupil is blocked with this discharge material, subluxated lens blocking the pupil, Phacomorphic glaucoma causing the obstruction of this pupil, aphakic pupillary block, where we remove the lens in protello, intracapsular cataract extraction, and did not do the peripheral iridectomy, which can block the pupil, so ultimately causing the rise in the intraocular pressure. Or the anterior chamber intraocular lens implant without iridectomy. So with pupillary block, Secondary angle closure glaucomas are where secondary causes are peripheral anterior synechia, usually in advanced neovascular glaucoma, chronic anterior uveitis, or ciliochoroidal effusion, ciliary body tumors, contraction of retrolenticular fibrovascular tissue due to retinopathy of prematurity or proliferative vitreoretinopathy. Now we will discuss certain secondary glaucomas, open angle type. So pseudo-exfoliation syndrome or the pseudo-exfoliative glaucoma. In this case, gray fibrogranular extracellular matrix or material similar to amyloid is deposited on anterior lens capsule, zonules, ciliary body, iris, trabeculum, or anterior vitreous face, so ultimately causing the rise in the intraocular pressure. Here you can appreciate the exfoliative material at the border of the pupillary border. And here you can appreciate the central disc of the exfoliative material and the peripheral band on the lens. What is pigment dispersion syndrome and pigmentary glaucomas? These are usually bilateral secondary open-angle glaucomas. So these are caused by mechanical rubbing of posterior pigment layer of the iris against packets of lens zonules. So as a result, excessive posterior bowing of the mid-peripheral portion of the iris. So this pigment is dispersed into the anterior chamber, it clogs the trabeculum, and it also settles on the posterior surface of the cornea endothelium. So here you can appreciate in this picture Krukenberg spindle where this iris pigments is settled on the posterior part of the cornea on the endothelium. Here you can appreciate the transillumination, the defects in the iris because this pigments are dispersed, blocking the trabeculum, and iris is no more obstructing the light. Similarly, you can appreciate by transillumination defect in the iris as the pigment has been shed into the anterior chamber by the constant rubbing of the iris on the zonules of the lens. So what are the lens-induced glaucomas? These are important for you and you must know what are its types. Phacolytic glaucoma, it is due to the protein. It comes out from the lens and settle down into the trabeculum. And Phaco anaphylactic, where the individual have a response against this own protein and causing the inflammation. So anaphylactic uveitis. And the Phaco-Morphic glaucomas are those glaucomas which are due to the shape of the lens obstructing the pupil, and this is the type of narrow angle type, and these are two types are open angle type. Phacolytic and phacoanaphylactic are open angle type, and Phaco-Morphic glaucoma is the narrow angle type, secondary glaucoma due to lens. So what is phacolytic glaucoma? It is also called lens protein glaucoma. It is open angle type of glaucoma in association with hypermature cataract, so that lens protein is leaked out and it is engulfed by the macrophages. So this high molecular weight lens protein and macrophages laden with proteins cause trabecular blockage. Interior chamber is deep and aqueous manifest floating white particles that may form pseudohypopyon when these particles settle down into the anterior chamber. So treatment of this phacolytic glaucoma is flushing out proteinaceous material and cataract surgery after controlling the, of course, intraocular pressure. Here in this picture, you can appreciate In phacolytic glaucoma, the edema of the cornea and this pseudohypopyon and deep hypermature cataract and gonoscopy, of course, will show the open angle. What is phaco-anaphylactic glaucoma? Phaco-anaphylactic secondary glaucoma is the inflammatory reaction of uveal tissue. So the immune system does not recognize this protein as itself. It is recognized as a foreign material and a reaction occurs, so causing the uveitis due to this released lens proteins. So usually it is in the hypermature cataract where the lens capsule is thinned out and the lens protein leak from the lens. Phacomorphic glaucoma. It is acute secondary angle closure glaucoma due to intumescent cataract. The lens imbibe water and it become bigger in size. So more apposition of iris lens apposition is there, causing the obstruction of the aqueous outflow from posterior chamber into the anterior chamber. So aqueous accumulates into the posterior chamber, pushing the iris forward and ultimately causing the irido-corneal contact. Once irido-corneal contact is there, there is sudden rise of intraocular pressure, causing all the symptoms of acute congestive glaucoma, but it is due to shape of the lens. And here you can appreciate intumescent cataract, fixed dilated pupil, and the corneal edema. And other types of glaucomas due to lens shape, when the lens is dislocated into the anterior chamber and it blocks the pupil, the causes are blunt ocular trauma, particularly a relative trivial trauma may be sufficient to cause dislocation of lens in ophthalmos and homocystinuria having weak zonules. Or in small lenses, particularly in microspherophakia and in Weil-Marchesani syndrome, where the zonules are also weak. So the trauma can dislocate the lens into the anterior chamber. So here you can appreciate the lens is dislocated into the anterior chamber, obstructing the pupil, and here it is incarcerated into the pupil, so that blocking the aqueous outflow through the pupil. So ultimately, rise of intraocular pressure there. What traumatic glaucoma or red cell glaucoma? So traumatic hyphaema due to trauma, blood accumulates into the anterior chamber. So it causes rise in intraocular pressure due to blockage of the trabecular meshwork by the red blood cells. So always whenever there is a hyphaema is called blood in the anterior chamber. You always consider two things. Two things are very important you have to consider in the examination. One thing is the staining of the cornea and other is the rise in the intraocular pressure. Whenever you noticed, yet you cannot tackle the rise in intraocular pressure by the medical treatment and corneal staining is there, always the answer is surgical evacuation. Otherwise, this corneal staining may remain permanent and causing the obstruction of the vision. So what is angle recession glaucoma? Angle recession glaucoma is due to blunt ocular trauma which rupture the face of the ciliary body. It is usually 6 to 9% of the patient who has previously blunt ocular trauma, they develop glaucoma. Glaucoma is unilateral usually, and history of trauma in the past, maybe sometimes a long time is passed until one have the glaucoma. Here you can appreciate the angle recession. Gonioscopy shows irregular scarred recessed angle. Here you can appreciate the recessed angle. And what is the treatment? Initially treatment is medical, but it usually fades. and ultimately you have to do the trabeculectomy, and if it fails, artificial filtering shunt is the answer. What is ghost red cell glaucoma? It is trabecular obstruction by degenerated red blood cells. It occurs approximately 2 weeks after vitreous hemorrhage. And the goose cells cross through a defect in anterior hyalid face into the anterior chamber. And these cells, which are devoid of hemoglobin, called goose cells, they visible as reddish brown or khaki particles. They obstruct the aqueous outflow by blocking the pores of trabecular meshwork. Glaucoma in carotid cavernous fistula. In this case, there is communication between the carotid artery and the cavernous sinus so that the venous flow become arterialized. So the veins become arterialized and intravenous pressure is increased, resulting into glaucoma because of raised episcleral venous pressure. Normal episcleral venous pressure is about 10 millimeter of mercury, but in this case it is much higher. So the aqueous cannot pass into the episcleral veins until and unless it achieves a high pressure. And gonioscopy may show blood in canal of Schlemm. And treatment you must do control the intraocular pressure medically until fistula resolves or is treated surgically. In secondary acute congestive glaucoma, pull and push method is there. Angle closure secondary to some other ocular pathology. As in neovascular glaucoma, diffuse retinal ischemia causes in central retinal vein occlusion and neovascularization in diabetes mellitus, chronic uveitis, and long-standing retinal detachments. This neovascularization in the retina and in the anterior chamber and on the iris causes rubeosis iridis. It causes angle closure like a zipraction. So pupil may be distorted, ectropia and uvea may be there, and you may find the vessels on the iris, rubeosis iridis, and the vessels at the angle of the anterior chamber. And gonioscopy show the synechial angle closure. So what is the treatment of neovascular glaucoma? The treatment lies to treat the underlying cause. You do the pan-retinal photocoagulation to divert the ischemia. Filtration surgery and drainage implants are the answer. But if they fail and eye is having no vision, you can ablate the silly body. So secondary acute congestive glaucomas type may be present in chronic uveitis where peripheral anterior synechia, posterior synechia causing or the seclusiopupillary or occlusopupillary may be there. Seclusiopupillary means posterior synechias are formed 360 degrees so that aqueous cannot pass through from the posterior chamber to the anterior chamber. And occlusopupillary, the whole pupil is closed due to this muddy discharge. So ultimately causing the iris bombi and irido-corneal contact and sudden rise of intraocular pressure. And trabeculitis is the inflammation of the trabeculum causing the rise in the intraocular pressure. Treatment is topical steroids and beta blockers. Inflammatory uveitic glaucomas, here you can appreciate angle closure with pupil block. And chronic uveitis causes seclusiopupillary. Here you can appreciate the seclusiopupillary along with posterior synechias. Whole of the pupil is clogged with the discharge. So it causes iris bombi. Here you can appreciate the iris bombi, ultimately causing the irido-corneal contact and causing the rise in the intraocular pressure. Inflammatory glaucomas without pupil block, where pupil is open. It is due to gradual progressive synechial angle closure. Peripheral anterior synechias are formed. Here you can appreciate the peripheral anterior synechias. They obstruct the anterior chamber angle. So it is usually due to the chronic uveitis. And what is the irido-corneal endothelial syndrome, ICE? It is usually unilateral and present in females. The abnormal corneal endothelial cell layer causes the angle closure. Here you can appreciate the angle closure due to the abnormal endothelial cell layer. And also you can appreciate iris atrophy, correctopia, and peripheral synechiae. And treatment of this secondary type of glaucoma is trabeculectomy and artificial filtering shunt. The tumors also causes the secondary acute congestive glaucomas or narrow angle glaucomas. The push method, where anterior displacement of iris due to iris lens diaphragm due to choroidal melanoma, retinoblastoma, or silly body melanoma, it pushes the iris forward, occluding the angle chamber. So treatment is of the underlying cause. This is all about the congenital glaucoma and few of the secondary glaucomas. Ladies and gentlemen, I am thankful to you for patient listening. Now I am giving you the assignment. Please send it as early as possible to the following WhatsApp numbers and email. And it is, what is congenital glaucoma? Please mention its clinical features, diagnosis, and treatment. Mention different lens-induced glaucomas, their pathogenesis, and treatment. Thank you very much, ladies and gentlemen. I am thankful to you for patient listening.